Third Annual Olfactory Neuroblastoma Patient Education Meeting.
My name is Gary Gallia, and I'm one of the neurosurgeons here at Hopkins. And on behalf of Dr. Nyall London and Dr. Murray Ramanathan from otolaryngology, we would like to welcome you to our third annual Olfactory Neuroblastoma Patient Education Day. We have a truly superb faculty for our talks and our breakout sessions today, including many from Europe. And we are very excited as for the first time this Patient Education Day is being concurrently run in Spanish. Let me share my screen here. My name is Gary Gallia. I'm one of the neurosurgeons here. I'm going to very quickly talk about a neurosurgeon's perspective of olfactory neuroblastoma. Several topics that I wanted to touch on today, many of which we've talked about already, include what that diagnosis means, the nuts and bolts of staging and grading. As we've heard throughout today, the role of the multidisciplinary team in management of patients with this particular tumor. I'd like to spend a little bit of time sharing our thoughts about surgical margins, how we think about that, and how that impacts surgical approaches. One cannot give a talk about surgery without talking about complications, which we'll mention, and then some thoughts about survival, surveillance, and some closing thoughts. So as we talked about earlier today, olfactory neuroblastoma is a rare tumor. Its incidence is about 0.4 per million people, so that turns out to be 140 to 150 people per year in the United States. This tumor arises from the neuroepithelium, which is at the top of the sinonasal cavity. This is a side view of the head, showing the nose, the brain superiorly here, and this bone structure that separates both of those, the skull base. And this is the olfactory nerve, this yellow structure here. And on a higher magnification, you can see that this nerve sends receptors down into the nasal cavity, and this is how our brain interprets smell. The airborne odors interact with these receptors. It's transmitted through these olfactory phyla, as they're called, into the olfactory bulb, and that goes to the olfactory cortex. These tumors are locally aggressive. They can extend and involve the nasal cavity, the paranasal sinuses, the skull base here, the cribriform plate, and they can extend into the intracranial cavity. And if they grow laterally, they can grow into the orbits. These can certainly metastasize most often to the neck and to other places in the body. The first thing I think about when I see a patient in clinic with a diagnosis of olfactory neuroblastoma is who read that pathology report and where that was read. And that's because, as we heard earlier today, this diagnosis can be confused with other tumors. And part of that is based on the rarity of the tumor. And secondly, it's based on the morpho-architecture that one sees under the microscope. This is one tumor that's in a family of tumors called small blue cell tumors. And this is what anesthesia looks like. The cells are small. They have this bluish color to them. And this family is very large. And this is a complicated table, which we don't need to spend any time focusing on. But on the left here are the number of tumors that have this small blue cell phenotype. And many of these are treated very differently. Some of them are even benign lesions. So understanding what that diagnosis is critical at the very start. And usually these tumors can be further characterized by immunohistochemistry. You're staining the tumor for different protein markers, and that's what is shown in this panel here for two particular markers in olfactory neuroblastoma. The other thing I think about, which we'll come back to at the end, is that patients do really well with therapy over long periods of time. We'll come back to that a little bit later. There are lots of different staging systems. We've heard about Kadish earlier today, and Dr. London showed the latest Kadish and Sika staging system. And we're not going to go through all of those today. The most widely used is the modified Kadish. Dr. Marita modified the original Kadish in 1993. And this is really based on the extent of the tumor. And Just to correlate some of this illustration with some anatomy, because I am going to show some pictures, and I know some of this is familiar already. This is a side view of the head. This is the CAT scan, which you can see based on the bone, and the sagittal view of the MRI scan. And this is where the cribriform plate is. So you have your nose, your sinus cavity, the cribriform plate that separates the brain from the sinuses, and then the intracranial space superiorly. If one were to take a slice, instead of looking from the side, look from the front and make a slice directly down this direction. You see this on illustration. So these are back of the orbits here. In between, you have your nasal cavity and paranasal sinuses. And this is what this looks like on imaging. Both CT, you have your eye, your orbits. Laterally, you have your nasal cavity in the middle, and then you have your skull base that separates the intracranial space from the nose and sinonasal cavity. And same thing on MR. On MR, bone is dark, so that's what one sees in this particular view. Here's the right eye, here's the left eye, and then here's the sinonasal cavity. So these tumors arise in the superior aspect of the sinonasal cavity and at the skull base. So how does that relate to Kadish staging? And as Dr. Hannah very nicely showed this morning, Kadish stage A is tumor that's confined to the nasal cavity, as in this particular patient that had a tumor extending off the middle turbinate. Kadish stage B tumors are those that are in the nasal cavity and the paranasal sinuses, such as this tumor, which is in the ethmoid cavity off on the left-hand side. Kadish C tumors are those that extend beyond the nasal cavity and paranasal sinuses. So this is a patient with a Kadish stage C tumor that has grown significantly inside where the brain is. And if the tumors grow laterally, they can grow into the orbits. And then D tumors are those that have metastasis to either cervical lymph nodes or distant sites. This is a very large neuroblastoma that involves the right and the left orbit. There's significant intracranial extension. And this is what a PET scan looks like. This is a PET scan showing a very large lymph node on the left side of the neck here. So this patient has a Kadish stage D olfactory neuroblastoma. In terms of grading really refers to pathology. So it's what a pathologist sees under the microscope. And again, this is a very complicated table. The details are not all important, but just to note that there's a lot of different features that a pathologist looks for under the microscope when these tumors are looked at. And they're graded 1, 2, 3, and 4. And really the general take-home message from this slide is if it's a grade 1 or 2 olfactory neuroblastoma, that's considered a low-grade tumor. And if it's a grade 3 or 4, that would be considered a high grade. In terms of evaluation, we really have a comprehensive approach to this, as many have mentioned this morning. We talked about pathology. We talked about the role of imaging to look at the extent of disease and systemic disease. And I want to mention the role of high-resolution skull-based imaging, both CAT scan and MRI, to look at the extent of the disease on imaging, the extent of disease at the skull base, the resectability of that tumor, and the approach that is optimal for that particular patient. And this is done in a multidisciplinary fashion. And patients are seen by otolaryngologists, neurosurgeons, as the tumor involves the space between the nose and the brain. There's often reconstruction that's involved, so facial plastic and plastic surgeons are involved. This tumor involves the eye, and ophthalmologists or neuro-ophthalmologists are involved. And then we have our oncology colleagues, both medical and radiation. And we typically have patients during their initial assessment be seen by our multidisciplinary team. And then each case is reviewed at our head and neck tumor board. In terms of treatment options, I'm going to share some thoughts just about surgery. We had some great talks today about radiotherapy, about systemic therapy, and most patients do end up getting a combination of treatment. Just a couple principles of skull-based surgery. So the first is really understanding what the goal of surgery is. Is it to get biopsy to establish a diagnosis? Is it a cancer operation? Or is it a palliative development kind of surgery? And for the most part, in olfactory neuroblastoma, the goal of surgery is an oncologic or what we call negative margin resection. And what that means is that the tumor is taken out and then the tissue around that tumor is sampled. And the goal of that surgery is to have all of those surrounding margins negative. And that is what we consider a negative margin resection. Now that has to be, it has to be kept in mind that, this has to be thought of in terms of minimizing and avoiding morbidity. So one would take out sort of only enough tissue that was needed in order to achieve that. And that means minimizing brain retraction and preservation of critical neurovascular structures. There's just a couple examples. Reconstruction is very important, and this is often planned before one even gets to the operating room. And that has to incorporate both what treatments a particular person may have had in the past, what subsequent treatment is going to need down in the future. And it essentially needs to be a reconstruction that will separate the intracranial space from the sinonasal cavity. And for those that have open procedures, which we'll talk about a little bit, we always have cosmetic things that we think about to maximize cosmesis. So a couple comments about margins. We talked about, the importance of margins, and there's many studies that have shown that patients that have negative margin resections from Olfactory Neuroblastoma and other tumors do better than those that have positive margins. And that's sort of why there's a lot of focus on that. And ultimately, it's the final pathology that we look at, but we do frozen section analysis at surgery to, in real time, look at what the margins are during surgery. And so the way that we think about these are contiguous circumferential strips of tissue around where the tumor is. And then these are analyzed by a pathologist during the surgery. And we think about these in three separate categories. There's a sinonasal set of margins that are sent for the tumor and the structures in the nose that are assayed. There's extracranial skull-based margins, so those on the bottom side of that bone, if the cribriform does need to come out. And then there's intracranial margins, so the dura, the olfactory nerves that are intracranial margins. And this is what they sort of look like. So this is a patient that has a Kadish neuroblastoma, had prior surgery, and this is what one sees at surgery. This is the dura that's cut. This is looking up the nose. This is brain, and this is the olfactory nerve underneath the brain. You can see this purplish tumor coming from that nerve. And then these are, in this particular picture, these are the sinonasal and the extracranial skull-based margins for this particular case. And we looked at sort of the performance of frozen section analysis during surgery compared to what the final result is on histopathology. And we looked at 33 patients in this particular study. There were over 450 specimens that we looked at. And, the bottom line is that our ability, or the pathologist's ability during surgery, to tell what is tumor and what is not tumor is very good, with a negative predictive value of 0.97. And the prevalence in our study was 0.2. Now, it's good, but it's not perfect. So that means, at surgery, sometimes there is a false negative margin. So at surgery, we're told it's clean, and then on final diagnosis, that comes back as positive. And we need to think about how that impacts additional discussions after surgery. And we could talk about that in more detail if folks are interested. Not surprisingly, there were more errors in grade 1 tumors, so the lower grade tumors had more errors than the higher grade, and that just makes sense because the lower grade tumors look more like normal tissue. Now, how do you get to negative surgical margins? I mean, how does that happen? And Dr. Hannah talked about this morning. So the most traditional way were open surgical approaches, and these are illustrated here. This is a picture showing an incision, a bicoronal incision with an incision on the face here. And then, this is the forehead that would be removed, and the neurosurgeon would work from above, and the otolaryngologist, head and neck surgeon, would work through the face to take out that tumor. And this is an illustration of what's called a mid-face degloving procedure, where a transcranial approach, taking off the forehead bones, would be combined with essentially pulling the skin up over the nose to get access to the sinonasal cavity. Now, there's an endoscopic assisted procedure where a transcranial approach where one would remove the frontal bones to be able to work down to access this tumor is combined with a more minimally invasive procedure to access and to address the sinonasal tumor. And that's what's shown here with an endoscope directly through the nose, sort of minimizing and avoiding all facial incisions. And then there are purely endonasal endoscopic approaches where there's no cranial incision, there's no facial incision. Everything is done completely through the nose. Now, I would propose, and the way that we think about this is that the best approach for the tumor, it shouldn't be based on any one of these a priori. It should really be based on the best approach to get one a negative margin resection. And that approach needs to entail the tissue for margin assessment. So when we think about surgery, we think about what procedure, what the extent of disease is on high resolution imaging, what is the best approach that can get us access to that entire tumor, including tissue for assessment of margin. Just to show a couple examples here. So this is a patient with a Kadish neuroblastoma, extends up intracranially, which you can nicely see here. This is a T2 weighted scan, which shows some fluid. This shows the fluid in the brain, and there's a nice fluid cleft above this tumor. So this patient was treated with a completely endonasal endoscopic approach. Very straightforward to do. This patient here, you would say, wow, that looks very similar to the prior one here. There's some tumor that extends up into the brain and, doesn't really come anteriorly and it doesn't really go into the eye. And so the important features in this patient was that he had prior radiation after his diagnosis, after a biopsy at another institution, and developed a brain abscess that was treated with antibiotics. And so while we felt comfortable that the sinonasal component could be removed endoscopically, we weren't so concerned. We weren't as sure that the intracranial compartment would be able to be cleared. So he had an endoscopic assisted procedure. So there was a transcranial approach to make sure that we can clear all of the intracranial disease, coupled with an endoscopic approach to address the nasal component. And this is another patient. You say, well, that looks very similar to the other two there that you just showed. And it is. There's a little bit of extension into the brain with a large mass here. This is a case we did about 10 years ago, and there was a significant extension laterally, and we were concerned that there was orbital involvement. So in this particular patient, he underwent an open craniofacial approach to ensure that we could maximize analyzing margins and resecting that lesion. Most of the cases that we've done have been done endoscopically, purely endoscopically. This is a paper that we published a couple of years ago looking at our experience just over a decade of 20 patients. There were 18 new diagnoses and 2 recurrent cases here. And I'm not going to go through all the details here. The majority of patients had Kadish stage C neuroblastoma, and most of them were Hyams grade 2. This is what the outcomes were from that group of 20 patients. We had one patient that recurred within a 5-year period of time. Our overall survival was 93%. And the patient who died here died of non-anesthesia neuroblastoma related issues. And our 5-year disease specific survival is 100% in this cohort. That means all patients are doing well. One of the other things that Dr. London gave a beautiful talk on just before this one is we are interested in understanding this disease from a scientific perspective. Based on how rare it is, there's been very little information on that. This was a study that we did where we collected anesthesia neuroblastomas over a long period of time, and we did a deep genomic analysis, and we found interestingly mutations in a gene called dystrophin, which is the gene found in muscular dystrophies. It's the largest known human gene. It's a cytoskeletal protein, and we found it in 86% of cases. So we're currently working on that. We don't understand how or why that causes, how it's involved in anesthesia neuroblastoma, but it is certainly a very large mountain in this tumor. Couple of thoughts about, we talked a lot about surgery, but sometimes surgery is not the first nor best choice. This is a patient that had about a year of sinus congestion, went to get this outside CAT scan, was told she had pansinusitis. And you can see there's no aeration in the nasal cavity, a couple little very small portions here. And on MRI, this is what her tumor looked like. So very large nasal mass, had bilateral orbital invasion, had extensive intracranial extension. This extended almost to the lateral side of the skull. And all of these other white marks here, she had what we refer to as leptomeningeal disease. So on imaging, she had evidence that the tumor was in the CSF, or the brain fluid spaces around the tumor. This is not a case where one would be able to get negative margins. So she underwent induction chemotherapy and followed by chemoradiotherapy. And this is what her scan looks like 2 months after therapy. This is after 5 months of therapy. This solid enhancing mass is less than here. And this is now 11 months out from surgery, 11 months out from treatment. In terms of complications, there are whole meetings on complications, just in general, how to think about them. We think about them as being post-operative. So an infection or meningitis. And that relates to the closure and the separation between the intracranial space and the sinonasal cavity, and whether or not there's a brain fluid leak at surgery. We always worry about air within the brain. Patients are often treated with anti-seizure medications due to the risk of seizures. There's potential risk for intracranial hemorrhage and other post-operative complications, as well as medical complications. Patients have other diseases that impact stress during surgery and post-operative recovery. In terms of longer-term complications, we heard a lot about this from in several of the talks in terms of nasal symptoms. Sometimes patients have prolonged crusting or nasal drainage, or toxicities from chemotherapy or radiation therapy. For patients that have open procedures, there's always cosmetic concerns that we have. Sometimes there's a fistula that forms between the sinonasal cavity and the medial aspect of the eye. And we heard a little bit about osteoradionecrosis in terms of the radiation sort of killing the bone, and then that can also be an issue, and long-term pituitary dysfunction from radiotherapy. In terms of survival, this is from that recent paper that Dr. London showed. Dr. Lechner and Dr. London, Dr. Hanna are the corresponding authors for this paper. This looked at 404 patients with Gallia and neuroblastoma, and the details here, the numbers aren't important, but what one sees is that patients do well over a long period of time. This is 120 months here. The other, I started the discussion by saying what I think about when I see patients with olfactory neuroblastoma, and Dr. Hanna showed a similar view with a larger experience. This is another paper from Dr. Hanna and his colleague, Dr. DeMonte at MD Anderson, looking at survival among the different histologies. So this black line here is olfactory neuroblastoma, and this is out at 20 years here. And one can see that they do much, much better than patients that have other diagnoses in the sinonasal cavity. In terms of surveillance, we heard a little bit about this today. It is critical for long-term surveillance, as these tumors can occur or can recur at extreme time periods after treatment. And we've had patients that have recurred a couple decades later. And it can be either at the site of initial disease, or it can be remote in the neck, subdural space, or distant metastasis. This is a patient that developed intracranial spread 4 years after a complete resection and radiotherapy. This is a patient that developed a metastasis in their parotid gland more than 10 years after their initial treatment. So it is critically important for a long-term surveillance. And so this is a very nice slide illustrating many issues, and we were just talking really about this disease progression, recurrence, and survival in the last couple slides. But cancer affects every aspect of one's life, and cancer survivorship concerns and care are very important. And this goes to what we talked about earlier in terms of the multidisciplinary team that's required for best care of patients with olfactory neuroblastoma. And we've had a couple of virtual community conferences this past year. One was in June, and one was in October. And we had two excellent speakers each time that talked about different aspects of cancer survivorship, which is also critically important as patients move forward. Couple concluding remarks, olfactory neuroblastoma is a rare sinonasal skull-based tumor. Treatment by a multidisciplinary team does provide the best patient outcomes. There are many excellent surgical approaches that are all important in treating patients, and programs need to have access to all of them. Adjuvant therapies are most often needed, and long-term surveillance is required. So I'm gonna stop and thank people again for sticking around and listening to an additional talk today. So thanks so very much. So to give a brief overview for the schedule today, there will be 4 main physician talks from various specialties who treat patients with olfactory neuroblastoma, and this really reflects a topic that will come up today in terms of the multidisciplinary care of patients with this tumor. Following these talks, there'll be 3 breakout sessions where patients and their families will be able to ask the faculty and additional faculty will join for these breakout rooms in a smaller group setting for any questions. Following this, there'll be a short break, and then Dr. London will give a talk about the future of olfactory neuroblastoma, both in terms of molecular genetic advances as well as upcoming clinical trials. And then following this, there will be an opportunity for patients and their families to share their experiences. Some patients have prepared some remarks today, and if others would like to speak, we will have that opportunity later today. And then there'll be a final question and answer discussion session to wrap up the day. So we are all very excited that folks are here in person and that folks are joining us online, and we are very grateful that you're spending a good portion of your day with us, and we hope you enjoy the meeting. So we will start our talks with Dr. Ehab Hanna, who is an international authority on olfactory neuroblastoma. Thank you. He is professor and vice chairman of the Department of Head and Neck Surgery at MD Anderson Cancer Center in Houston, Texas. He is the director of the Multidisciplinary Head and Neck Center and the co-director of the Skull-Based Tumor Program at MD Anderson. He has published extensively on olfactory neuroblastoma, and we are delighted to have him with us today and look forward to his talk. So I will stop sharing. Murray, you can hear. Yep. Okay. Yep.
All right. And can you see my slides?
Yes, perfectly. Perfectly. They're in presenter mode. They're perfect.
All right. Great. So I was tasked to kind of give an overview and cover particularly the surgical aspect from an otolaryngology or ear, nose, and throat standpoint. So I'll try to do that. And I was given somewhere around 15 to 20 minutes. So I will stick to that timeline as well. So olfactory neuroblastoma was first described by Berger, Luc, and Richard in 1924. And since that time, it's been called a variety of things. But the 2 accepted terms today is esthesioneuroblastoma, but the most accepted term is olfactory neuroblastoma. But you could hear both terms used in the clinics and the hospitals and doctors' offices interchangeably. It's a very rare neoplasm with an overall incidence of less than half a patient per 1 million of the population per year. So extremely rare tumor. It really starts from the roof of the nose, the area that we call the olfactory cleft. And this is the area where the nerve fibers and receptor cells for the sense of smell reside. Of course, it can occur also in areas other than the roof of the nose, lower in the nasal cavity and the sinuses. And the most likely cell of origin, or where it comes from, is the basal neural cells of the olfactory mucosa, which is the sense of smell area. So just to kind of show you how rare it is, looking at the MD Anderson database, and this is looking at all sinus cancers that we have seen over the years with at least a 5-year follow-up. Olfactory neuroblastoma was less than 10%. Actually, it was 5% right here, as you can see from these, by now almost 4,000 patients. The database needed to be updated to include the last several years. But you can see here some of the other neoplasms that happen in this area. But for the topic of today, that arrow shows to a 5% of all tumor. And there's been a lot of advances, and I'm going to share a little bit about that with you, both in the diagnosis using endoscopy in the clinic, high-resolution imaging like CAT scans, MRIs, PET scans, but really for the pathologist to better understand the biopsy. And I'll talk a little bit about that and how critically important that is. Then we'll cover advances in treatment, particularly surgery, and then you'll hear later on about radiation and other drugs. But are we making progress with all of this? Are we improving? And you can see that all sinonasal cancers here, this is a graph showing the 5-year survival rate by decade. So the 40s and 50s, all the way to the 60s, 70s, all the way to this current decade here. And you can see that the 5-year survival has been increasing by about 5 to 8% per year. And when we started back in the 50s at less than 30%, and now almost at 80%. But the main point today here is that the top curve, if you look by type of cancer, the top curve here is olfactory neuroblastoma, meaning that of all the sinus cancers, olfactory neuroblastoma has the best survival. Of course, no one wants to have a sinonasal cancer, but if you're going to have one, olfactory neuroblastoma is probably the one to have. And this is a 5-year curve. This is a 10-year curve, again, showing that even at 10 years, olfactory neuroblastoma is at the top of that survival curve. So I try to come up with some questions that my patients usually ask me, hoping that I will cover a lot of what you want to hear today. What is the optimal clinical evaluation? What kind of imaging should we get? What is the importance of accurate diagnosis or pathology? A lot of people want to know about the staging system. Something happened here where I cannot advance anymore. Sorry about that. Can somebody kind of guide me into... Let's see. Can you still hear me?
We can still hear you, Dr. Hannon, perhaps just reloading from that spot there, maybe.
Okay, so what is the ideal staging system? What is the best choice for surgery? How much surgery should be done? What about reconstruction? What is the role of additional therapy? And you'll have 2 specific talks for that, so I'll just give the highlights on it. And how do we treat the neck and the lymph nodes if that needs to be addressed? You're going to hear about the role of chemotherapy. And does the high AMS grade, and we'll get to that here in a minute, have any effect? And what are the long-term outcomes? So what is the optimal clinical evaluation? In other words, when you go see your doctor, what is the best way to go about getting an assessment of your situation? So just to share with you some of that, our experience with the last 140 patients or so with olfactory neuroblastoma, you know, there's no age limit. We've diagnosed it as early as less than 10 years old, all the way to over 80 years old. But the peak or the median is 52 years old. And the symptoms, as you can see here, the most common really is nasal blockage or nasal obstruction, particularly on one side of the nose. Epistaxis is a bloody nose, and sometimes people will come with symptoms that sound like or look like sinus infection or sinusitis. Others will come in with headaches, facial pain, loss of smell, which we call anosmia, and some visual changes. Of course, later on, if the tumor is more advanced and invades the brain, you can have other symptoms. And just to show the frequency of these symptoms, we've recently compiled a little over 400 patient experience with 12 centers over 5 countries, and this paper was published recently, showing that nasal obstruction is present in about 2/3 of patients, and bloody nose, which is epistaxis, in about half of the patients. Loss of the sense of smell in about 1/4 of the patients. After the doctor takes a very detailed history, then what they'll probably want to do is put a camera in the nose. And this is the normal side. This is what the nose looks like. The nasal passage and these structures that you see are called the turbinates. We look at the roof of the nose. This is on the right side of the nose. That's the back of the nose where they get the COVID test with a little swab. This is the left side of the nose. And when we put the camera in, you can see in the center of the screen this red, fleshy mass, and that is the olfactory neuroblastoma. So the point of this video is not to gross anybody out, but to really tell you that we have high fidelity optics that allow us to see the tumor directly and assess it intranasally. Then people will ask, should I get a CAT scan or an MRI, or how does my doctor choose the imaging modality? And here you can see this is a CAT scan. These are the eye sockets right here. This is the brain. And bone is white. And there is a defect in the bone here where the olfactory neuroblastoma, this gray.
Finally, yeah. Took some doing. It's just one of the doctors talking, so I'm just going to leave it on for a little bit. And I'm not going to sit here for 2 hours watching it.
If I may just interrupt Dr. Hanna for one moment there, for people that are on the remote, if they can just mute their computer, that would be helpful so there's minimal noise during the presentations. Thank you. Pardon me, Dr. Hanna.
Thank you. So I was explaining here that on the CAT scan, the bone is white and the gray stuff here is the tumor. And you can see that normally we would have a shelf of bone right here, and that has been destroyed by the tumor. This is the same patient with an MRI showing actually the tumor going upwards into the brain here and over the eye. The point of this slide is the following. CAT scan shows the bone detail really well, and MRI show us the soft tissue or fleshy detail a little bit better. This is a side view showing the same thing here again.
Yeah. You got so many pipes up here that your limits. We can have 5 per person. Yeah.
I'm sorry for pardon the interruption one more time. There's somebody that has their audio still on the video, and we can hear the discussion in the background. I'm not sure that person can mute their computer. Maybe it's Connie. If you can mute your computer there, that would be helpful for us. Thank you.
So this obviously is an MRI again showing the 2 eye sockets here, the brain. And this cyst here underneath the brain is something that we see commonly when tumors approach the undersurface of the brain matter itself. Now, people will ask about PET scans, and I try to get PET scans on all my patients because not only it looks at the head and neck area, but it looks at the lymph nodes that are perhaps not as visible. This is an MRI, and you can sort of make out this circular structure here, but it lights up on the PET scan, and it makes it very easy to see. And also, the PET scan will cover the lungs, the liver, the rest of the body, and the skeleton or the bone. Now, more recently, we have been getting a special type of PET scan called dotatate PET scan. and it's highly, highly specific for olfactory neuroblastoma. Not only it is specific and it lights up like these are three different patients. This patient has two spots, one in the neck and one in the covering of the brain called the dura. But it also, if it lights up on the PET scan, it tells us that this patient has the somatostatin receptor, SSTR, in their tumor positive, which you will hear later on about that, how that can be targeted with specific targeted therapy for treatment. Probably the most important thing I'm going to talk about today is this one here. What is the importance of accurate pathology? So when a biopsy is done, what is the importance of actually getting the diagnosis right? So the top panel here is olfactory neuroblastoma, and these are two other cancers that look like it. And obviously, all these images and panels don't make any sense except for a pathologist. Even me, I can't really figure out all these minute differences. But these minute differences make a very important decision about the type of tumor we are dealing with. And just to show you what that impacts, so this is esthesioneuroblastoma or olfactory neuroblastoma, and these are the lookalikes, and that's the survival rate. So obviously, you want to be able to make sure that you belong to this group here and that you are not being treated for olfactory neuroblastoma, but you actually have something else. Or vice versa, that you're told you have one of these more aggressive cancer, but indeed you have olfactory neuroblastoma. So how do you ensure that you do that? Well, I would advise that you either go to a high volume center where the pathologist sees a lot of olfactory neuroblastoma, or at the very least have the biopsy material sent by mail, Federal Express or something similar, to a pathologist who is experienced in the diagnosis. And what they do is, and again, this is not to go into any detail here, but they do different stains here. These are all the stains that you use to color the slide and the biopsy material, and the different markers or the different colors and stains that they use bring us to the right diagnosis. Now, a lot of patients will ask me, what stage do I have and what staging system do we use? And there have been a lot of different staging systems, but I want to leave with you two most commonly used ways for us to assess patients and the extent and the type of their disease. The first one, and probably the most used, was first published back in 1976 on only 17 patients. This was from the Mass Eye and Ear Institute in Boston. And essentially, it's the simplest method, really, to stage olfactory neuroblastoma. And it's called the Kadish System. Sidney Kadish is the doctor that first came up with that. So stage A is limited to the nose. Stage B, when it moves from the nose to the sinuses. And stage C, when it moves beyond the nose and the sinuses. So pressing on the eye, going into the brain, that kind of extension. Of course, they added stage D later on. Dr. Morita added that in 1993 to describe spread to either the lymph nodes or beyond the head and neck, and that is stage D. So A in the nose, B in the sinuses, C beyond the sinuses and the nose in the head and neck area, and then D, lymph node metastases or other organs. And this is, again, the breakdown of our patient experience here. And you can see that almost half the patients come with stage C disease. The good news is, and as I'll show you recently, is that the survival or the outcome is still excellent, even for advanced stage disease. The second way we look at this is not so much the stage, but the what we call the grade. The grade is basically how, you know, how people talk about cancers that are either fast growing or slow growing, cancers that want to metastasize or not metastasize. That's the behavior of the cancer. And the behavior of the cancer is closely linked to the grade of the cancer. So roughly we have 4 grades. This is not staging now. These are 4 grades of behavior. Grade 1 is the slowest growing and most sort of indolent or chronic or slow behavior, and grade 4 is the most aggressive, the fastest growing, and the worst of the 4 degrees of behavior. And again, all these things you see in the table are the pathologist's job to try to give us the grade. But to make it easier for you, roughly speaking, grade 1 and 2 combined are slow growing and low grade, and grade 3 and 4 combined are what we call high grade or fast growing. And this has some implications on the intensity of treatment. Going to surgery, and I'm going to tell you that 92 to 95% of patients with olfactory neuroblastoma will be treated initially by surgery. And today, there are 2 major ways to think about surgery. One that is open, where the surgical team will use external incisions, either on the scalp or on the nose to access the tumor, or endoscopic, where the surgical team will put cameras through the natural passage of the nose to access the tumor. The advantages, obviously, of the camera or endoscopic technique is that it's less invasive and it provides direct access to the area of the tumor. It avoids the facial incisions and the bone removal necessary to get to the area of the tumor. But perhaps even better than that, it provides better vision because you put the camera right where the tumor is, and it allows you to see around corners compared to using angled endoscopes and angled cameras compared to the traditional technique. And this is kind of our practice from 2000 to 2016. And the blue bars is the surgery that was done for this area of the body using the endoscopic or the camera technique. And the purpose of this slide is to show you how more and more we are moving into this minimally invasive surgery as opposed to the open surgery. Now, here's an example. The top panel shows a tumor that is ideal for the camera or the endoscopic technique. It's a relatively small tumor. It is situated in the nasal passage between the eyes. It goes up but not through. The side view here shows that the wall between the brain and the nose is intact. The tumor has not gone up. So we removed this through an endoscopic technique, and this is 7 years afterwards. That white stuff, which is the tumor, is no longer there in all these views. In contrast, this is a tumor that obviously is larger, but also extends significantly, pushing the brain upwards. But more importantly, these 3 arrows shows that it shows kind of a side spread over the left eye socket, something that the camera technique or the endoscopic technique has a difficult time clearing without making some sort of incision at the top of the head. So this one was done in an open fashion, and you can see, again, 7 years later, this tumor that was present here, this is the before, this is the after. Again, these are the 2 eyeballs and the tumor between them, and this is after. So the point I'm trying to make here is that there are many tools in the toolbox, and you have to choose the right surgery for the right patient based on the location and the extent of the tumor. And then the question is, how much surgery is needed? I mean, do we always need to remove that area underneath the brain? Do we always need to remove the base of the skull? And this has been an area of debate for a long time. But today, you can see that we have proposed at MD Anderson to think about this as 4 degrees of resection. One that is primarily in the nose without affecting anything of the base of the skull. The second is to remove the base of the skull bone, but not the covering of the brain, because the tumor sits right underneath the brain without extension into the covering of the brain. Here you can see that the tumor breached this line right here, which is the undersurface of the brain. So then type 3 is removing the dura, which is the covering of the brain. And then type 4 is actually removing some of the brain matter itself. And you can see here that this tumor extended not just into the covering of the brain, but into the brain matter itself. Now, after surgery, what reconstruction should be done? And obviously, we have to rebuild what we took out. We have sort of a resection team and a reconstruction team, and it really depends. Is it small, medium, or large? And the most common reconstruction is what we call a multi-layer reconstruction, meaning we stack up 3 or 4 layers of tissue. The most commonly used, the fascia lata, is tissue we get from the side of the thigh. And then we put a couple of grafts from that. And then we use tissue from the nose itself. This is called the nasoseptal flap, and that's the pink one. So the fascia lata is the yellow, and the pink one is the nasoseptal flap. That's the second layer. And then we put some absorbable material in the nose to support that reconstruction until it's all set. Now, if we have a very large defect, then we harvest tissue from the forehead over the skull bone and move it underneath the brain. That's this line right there that separates the brain above from the nose below. And this is a very large area that can be covered using this tissue. And essentially, we haven't seen a defect large enough to not be able to be covered with this tissue. In other words, this forehead reconstruction gives us everything we need to perform the reconstruction. So with these types of surgical approaches, again, this is to show you that 92% of patients had surgery first, and of these, about 2/3 or more of them had purely endoscopic approach. And I'm gonna go through that. So you're gonna have a couple of talks about radiation and chemotherapy. So I'm not gonna talk about that because I want the other speakers to have a chance to tell you about that in more detail. But I'm going to end here with the outcomes, because I think people are very interested in saying, okay, what is my outlook here? How will I do? What is my prognosis, if you will? So I'm here to be the bearer of good news and tell you that overall, we measure the outcome. Probably the most sensitive measure is what we call disease-specific survival. So survival basically means living, as you know, and disease-specific meaning that we only count people who did not make it because of the olfactory neuroblastoma. And then we count those who did. So the 93.4% is a 5-year of those who survived and did not have a mortality because of olfactory neuroblastoma. Now, overall survival measures the mortality from other things. You know, people have heart attacks or, old age or, pneumonia or something like that. So we don't count that in disease-specific survival. But in disease-specific survival, we count the mortality from the disease itself. And at 5 years, 93.4% in our patient population at MD Anderson were alive, and olfactory neuroblastoma did not cause their demise. At 10 years, that number is still over 80%. Despite that excellent survival, there is another number that is a little bit more concerning, which is recurrence. So what we're seeing here, unlike other cancers, is that recurrence, meaning the cancer coming back, is an event that keeps happening over time, unlike other cancers where 2 years out, 5 years out, you're done. You know that if you're free of disease, you're free of disease. With olfactory neuroblastoma, recurrence can happen later on. And you can see here that the recurrence can happen all the way 10 or 15 years later. But the good news is that most of these recurrences, and this is very important to know, are treatable. And again, the survival and getting rid even of the recurrence is still very high. So in order to stay on time and keep my talk focused on what I was given, I want to conclude by saying that olfactory neuroblastoma has an excellent survival outcome, that surgery with radiation, you'll hear about that, is the cornerstone of treatment, that minimally invasive or endoscopic approaches are becoming the standard or more common at least, and provide a reasonable surgical approach, of course, for tumors that are amenable to that. And the neck, the lymph nodes in the neck, if they are not enlarged and palpable, and viewable on a CAT scan or MRI, we call that the N0 neck, meaning there's no evidence of that. And for these, we've adopted a radiation approach to the neck as opposed to a surgical treatment of the lymph nodes in the neck. Now, surgical treatments for the lymph nodes in the neck will be applied if there are obvious lymph nodes in the neck. And then finally, despite this excellent survival, recurrence might be delayed, highlighting the need for long-term surveillance. In other words, once you have been treated for olfactory neuroblastoma, you need follow-ups for life. And perhaps the most important thing for you to know that you need an experienced multidisciplinary team that involves a whole team of surgeons and medical and radiation oncologists, expert pathologists to establish the right diagnosis and to select the best treatment outcome. So I'm grateful that our group of surgeons depicted here are all focused on this area, all of them dedicated to treating olfactory neuroblastoma, and that it goes beyond the surgical team. It really, you can see here the surgical team at the top, but we have obviously the speech pathology, the medical oncology, the neuroradiology, pathology, radiation, and oncologic dentistry. This is our conference that we do every week to discuss every patient that we see, and as a team, collectively try to figure out what is the best treatment for them. So with that, I'm going to conclude, and thank you very much for your attention. And I'll stick around for any questions later on. I appreciate the privilege of being with you this morning. Thank you.
Thank you, Dr. Hanna. That was a terrific talk. I have always enjoyed your presentations, and today was no exception. I really appreciate the comprehensive view and the clarity with which you speak. So thank you. And, I think we will hold questions until the end of the session.
So I don't have anything to disclose or any conflicts of interest. So we're going to talk about some overview, some general principles, some key aspects of radiation therapy role in this particular disease. focus on some new technologies or new techniques that we have implemented for the treatment of neuroblastoma or skull-based tumors in the last few years. The treatment-related toxicities and how to follow up these patients, and then some conclusions and future directions. So as Dr. Hanna already mentioned, a lot of the natural history and biology and staging of the disease, there's some general principles for neuroblastoma. So it's uncommon, and they are rare malignant tumors. They arise from the olfactory epithelium. So as we have talked, is on the roof of the nose in this area. And therefore, because of their location, they have a tendency to spread in different locations into the brain, into the eyes, or into the nasal cavity. Their more common symptom presentation is nasal obstruction or epistaxis. They are locally aggressive with the tendency to involve adjacent organs. The staging system was also being described by Dr. Hanna. So we usually use the Kadish system, who actually was described by Dr. Sidney Kadish, who was a radiation oncologist, and the Hyams histological grading, you know, how the cancer cells, they look into their microscope, they are prognostic for this disease. A key principle here is that it requires a multimodality treatment, meaning surgery, radiation therapy, and chemotherapy, and these tumors also have high rates for local recurrence. So this is just a diagram of the potential patterns of local spread of the disease. As we spoke, they tend to arise around the olfactory nerve at the roof of the nasal cavity, and just right above we have the brain. Behind we have like the pituitary gland or the cilia turca. Then we have the entire nasal cavity underneath. So those are particular areas of interest in this disease because of the potential tumor spread. And then next to the nasal cavity also we have the orbits or the eyes. That as well, some of these patients can present with vision changes or eye problems due to their local invasion of the disease. And I think this is the more important slide of the entire presentation. So we require a teamwork or a multidisciplinary approach for the best outcomes and to succeed on the control of this disease. Obviously, this has to be focused on patients, so patient-centered. But as you can see here, there's so many different specialties and groups that will need to be integrated, like the neurosurgery or skull-based surgical team, medical oncology, pathology, obviously very important to have the correct diagnosis to choose the right treatment option for the patient, ophthalmology, endocrinology, reconstructive surgery, radiology, and other specialties like dentistry, psychiatry, palliative medicine, and physical therapy. And in big institutions, including Mayo Clinic, we usually also get together once a week to discuss all skull-based cases at the skull-based tumor board. And we also have constant communication about these discussions and about all cases almost on a daily basis. So how radiation therapy works. So ionizing radiation, it's a local treatment. So that's a big principle there. So we just focus on the area that we can treat. Usually for neuroblastomas, it's done in the adjuvant or on the post-operative setting in the vast majority of the cases. In very specific circumstances, it can be done when surgery is not possible, it's not an option. And the duration of the treatment and the dose, it really depends by individual case and by the results of the surgery. But typically, it's going to be between 6 to 7 weeks of radiation when we're looking for a curative intent. And it's something between 60 to 70 grays in terms of the dose for the treatment. And how it works, well, there's two ways that radiation can interact at the molecular level or at the DNA level. So one is called the direct route or the direct effect, where radiation just goes and basically damage the double strand or the strands of the DNA, as we can see here on the picture. And then there is the indirect effect. Well, it's also a very common way that radiation works at the cancer cells, where it interacts with the water or the within the cancer cell or the cytoplasm, producing free radicals. and those free radicals travel to the DNA strand when they are close to the nucleus, and then again, ultimately damage the DNA and cause the death of the cancer cell. So what are the treatment modalities? So there's basically two main treatment modalities for radiation therapy. So one is called photon radiation, also known as conventional radiation or X-ray radiation or X-ray therapy. And usually what it means is a technique called IMRT or intensity modulated radiation therapy, which is available in most places in the United States. And in another way, it's called radiosurgery that has different platforms, gamma knife, cyber knife, or LINAC, stereotactic radiosurgery. We're not going to focus too much on that modality of technique today because radiosurgery usually is more done when there are small focal tumors, usually in the recurrent setting. And then I'm going to try to focus more today in the second modality called proton radiation therapy or charged particle therapy that has been in increased use in the last few years in the United States for the treatment of skull-based lesions due to their particular physical properties of the protons. And the one that are more common now, or the newer technologies, is called pencil beam scanning or intensity modulated proton therapy that can really scope and target very precisely within millimeter precision, the tumors at the skull base, while we are limiting and reducing the dose of radiation to the adjacent or the surrounding normal structures. So why to choose proton therapy for this particular disease? Well, it's very simple. It's just because they stop. And I'm going to spend the next few slides to trying to explain what that means. So as we can see, one of the main advantages of the protons is this concept called the Brack peak curve, where we can deposit through the proton therapy some dose inside of the tissue to a certain depth, as we can see here on the left side. And this Brack peak was described by a physicist, and what it means is that the proton therapy or the charged particle has the capability to quickly, at the end of a range, deposit all his energy and dose, and then have a very rapid follow-up of the energy once it does that. So it kind of create this particular peak, or called a Brack peak, and then you can really limit the dose that normal structures or organs are receiving. However, what are the potential disadvantages of the protons is that we need to know where to stop, right? You can have the pristine technology and the pristine machine and all that, but if you don't stop or don't know where the protons are stopping, then you still can cause harm and potential damage normal organs. So with the newer technology, particularly with the pencil beam scanning, we can spread that Brack peak in different positions to just really basically paint out the tumor in a very precise and efficient way and safely. So this is just another representation of how these protons will look kind of like in a very schematic way within the body or within a contour of a patient. So we have the entrance of the beam of the protons, and then it just goes and creates this Brack peak where the tumor is located, and then just really have a very rapid fall-off of those and energy right after. And we can see here where, for example, other areas here will not receive really any further radiation. Versus on the upper curve of the diagram, the typical conventional photons or X-rays or IMRT, there's an entrance of the beam and there's going to be an exit of the beam, meaning there is more spillage or scattered dose from the radiation to surrounding organs. And usually what it means is more potential side effects and toxicity. So this is just kind of like a nice video for a brain tumor that is going to basically show you how conventional X-ray or IMRT compares to proton in a more schematic way. So I'm just going to run it for a second. So that's the X-ray, the MRT. So there's an entrance and an exit of the beam versus the proton therapy or pencil beam, how we are going to basically pencil out or scan the tumor in such a precise way that we are just really focusing on the tumor and not in other structures. And just the comparison, more radiation with the conventional to normal organs versus just really more targeted therapy for proton beam. So when a patient comes to the clinic, what are the radiation therapy steps? So it's always going to be basically these 5 steps. So an initial consultation or evaluation, then it's called the CT simulation, where we're going to map the area that we need to treat. Then is the treatment planning process, the treatment delivery, and how we follow the patients during and after treatment. So I'm going to go quickly in the next few slides about explaining this process. So the same as the multidisciplinary team approach in radiation oncology, there's also a big team or a lot of people that will be working behind the scenes in the treatment plan and in the delivery of the radiation to obtain the best outcome. So there's a strong communication between the physician or the radiation oncologist, the physicists, the dosimetrists, meaning the people that also help with the planning of the radiation therapy. It's a big group of engineers, schedulers, social workers, people that also have patient access managers that help for insurance, etc. Radiation therapies, the technicians that usually work on the machine for the setup and the delivery of the radiation, and then the nursing team. So again, teamwork, it's key for the success. For the consultation, initial evaluation, physical exam. We also usually, same as the surgeons, we do a scope exam to evaluate and have a better look of the location of the disease. Complete staging workup, like doing MRIs or PET scans, and then referrals to different specialties if needed for that particular situation. So just another representation of a scope exam where we have like a tumor kind of like in the back of the nose. These are MRIs of Stishon neuroblastoma tumors that, as is being also mentioned before, they can be bulky tumors in very critical locations close to the eyes that can cause obstruction symptoms, bleeding, or visual changes, etc. And that usually surgery is the upfront treatment approach, but radiation can help in the adjuvant setting to improve local control and decreases the chances of locally recurrence. The MRIs can also be used for the location and tailoring of the radiation. So we frequently, almost on every case, will do treatment planning MRIs to help us again to be more precise with our radiation delivery. Another example here of a tumor that is so close to the main right optic nerve. So this patient presented with decreased vision on his right eye. And then this is a PET scan that also will be used for the treatment planning and then the delivery of the radiation. Then it's called the CT simulation process, where we are going to have to immobilize the patient and do the particular setup of how the patient is going to be treated for all these weeks of radiation. We usually like to start within 6 weeks after the surgery, the radiation. We create these specific molds, or called thermoplastic mask, that is going to be used for the setup of the patient on a daily basis. We also took a CT scan with IV contrast, and we also coordinate with other treatment position scans, as we spoke, MRI and PET CT scans that we use for the planning of the radiation. So this process takes about an hour of the patient, and it's the more critical process of the radiation planning. Then we start with the treatment planning. So or it's called contouring or delineation of the tumor volumes. At Mayo Clinic, we obviously will focus where the primary location or the primary surgical veil is, and then also we tend to favor do elective nodal irradiation or treat the necks bilaterally in these cases due to the improvement on local regional control with radiation therapy. We also will use the scans that we're taking to define what are the organs at risk on a particular case, start with a plan calculation, then plan evaluation, and then we do a lot of quality assurance, quality control metrics to make sure that the delivery of the radiation is going to be safe for everyone. And all this process takes about 10 days for proton therapy. So this is just how we paint or contour or delineate the target volumes of a particular case. This is obviously, as we can see, this is a postoperative case that we are basically targeting the entire nasal cavity. This is an axial view, and then this is a sagittal view, how it will look for the target volumes. Then we also focus on the organs at risk. So here on the left, we can see how the retina of the right eye is contoured, the right optic nerve, the optic chiasm, the lenses. So all these vital structures we want to avoid from any radiation therapy. And then here on the right, on a sagittal view, we can see the contour of the brain stem, spinal cord, your pituitary gland, the optic chiasm, and then some swallowing muscles also. That also we will not want to treat, and we want to avoid as much as we can from radiation therapy. And then this is how it will look like a radiation plan for protons. You see how nicely we are able to sculpt the radiation dose from the eye on the right side and on the left. So that means that we are sparing for any complications there. Also how it's also away from the optic nerves and then from the brain and from the more posterior structures. Then we do all these evaluations with the dosimetrists and physicists to make sure that we are achieving and delivering what we want for that particular case as well. We also, during the treatment, we're going to make sure that what we initially planned is constantly delivered on a daily basis. We do imaging to check of the positioning of the patient before each individual treatment. For proton therapy, I'm going to explain it in the next few slides. It's about 45-minute process that the patient has to be inside of the treatment room. And we do all these verifications, scans, or adaptive planning for, again, assurance that the treatment is safe and proper for that patient. And he will see our team, including the physician, once a week for symptom management. This is how the room of a proton machine looks at Mayo Clinic. This is what it's behind the scenes, all these big machines and structure for the delivery and the production of the protons. This is a synchrotron that basically accelerates the protons, and then it goes through the gantry or the head of the machine, and then it goes into the room where the patient is basically laying down on the table. And then this is just kind of like the structure here. So we see here the beam that produces the protons, then they go this way where we have the synchrotron where it accelerates the protons, and then we have all these different rooms here, 1, 2, 3, and 4, so that they will receive the pulses of the protons, and then it's delivered where the patient is lying down here on the table. So that's what I said, it's about 45 minutes process because it needs to be produced, but also the delivery of the protons is not simultaneously for every single room. So the patient will need to have some waiting time while other patients also can receive their treatment. And also important is to have CT scans or CT on rails on the treatment rooms where we can double check that what we initially planned at the time of the simulation with the CT scan, it's what also we are seeing that day on the treatment room. And what it's important because there's going to be changes on tumor volume or tumor shrinking. There's sometimes some secretions or mucus on the nasal cavity that also affects how the radiation is delivered. There's also weight loss, changes in position of the mandible or the neck, and all these different metrics that we check again for safety. So this is an example how if the positioning of the neck is changed, there is some air gaps here on the back of the neck, and then that can definitely affect the way that the radiation is delivered. For example, here we can see here a patient has weight loss with some lymph nodes on the right neck. If you have those changes, the way that the radiation is delivered, you see all those white curves is changing compared to here because of the neck volume from weight loss. So those things are very important. We check that very carefully, and we change plans accordingly for the actual delivery of the treatment. And again, for changes on the nasal cavity from mucus or secretions, positioning of the mouth and all that, you can see how these different colors or radiation doses are changing or can change the way they are delivered. In terms of side effects, they are divided in acute or during treatment or short after, and late or long-term side effects. Obviously the ones that we really want to avoid are more the late or long-term side effects that can obviously be permanent, like vision and hearing changes, dead tissue of the brain or the brain stem, bone or soft tissue necrosis. This also can be called damage to the pituitary gland. That is a gland that produces so many hormones that are vital for our body. Hypothyroidism, some changes on taste and smell, dry mouth, fibrosis, etc. So with better surgery, better technology, with radiation, we're more precise. We have a tremendously advantage on decrease on the side effects in the last, I would say 10, 15 years, and we continue to get better, but it's something where we took very carefully and we follow very closely our patients, and that's what also started my presentation, that the multidisciplinary approach with all these specialties involved are key for the success, not only for the cancer control, but also for the long-term function and cosmetic outcomes of the patients. How we follow the patient, usually 6 weeks after radiation, we'll see them for symptom management, see that the patient is getting better and recovering from the treatment. Then at 3 months, it's a big milestone for patients, and we want to have a physical exam and scope and restage scans that are negative. And then we follow closely between the other specialties, particularly with surgery every 3 to 4 months for the first couple of years, every 6 months for year 2 to 5, and then once a year or so after year 5. But as Dr. Hanna mentioned, there is also very important the long-term surveillance, meaning these patients will have follow-ups for the rest of their lives, and then we'll coordinate with the other multidisciplinary teams. So what are some of the take-home message and future directions? So this is a challenging and complex disease that requires a multidisciplinary approach and multimodality treatment to obtain the best outcomes. But we already, as we have discussed in prior talks, the outcomes are pretty good. Radiation therapy plays a key role in the management of the disease, particularly in the adjuvant setting, to improve local regional control. Proton therapy allows to deliver high doses of radiation while limiting toxicities. And we still need to focus on continue research efforts to have a better understanding of the biology of the disease, to continue to improve outcomes, decrease toxicities, and move forward to precision medicine. Particularly, we have a strong interest on tissue biobanking and molecular tissue analysis to find new biomarkers and have better understanding of the biology of the disease. And I just want to finish my talk with two of my favorite sentences from the Mayo brothers. The needs of the patient come first. And as we have talked through the entire discussion today, the keynote of progress is system and organization. In other words, teamwork. So it needs a lot of specialties to be involved for the success in this. This is the radiation oncology head and neck skull-based team where I work, and I'm proud to lead. And with this, I just want to say thank you for the opportunity and the honor to participate today in this discussion, and we'll be seeing and talking to all of you shortly for further questions. This is a photo of the Mayo brothers, and this is how they look now in Rochester. And thank you for your time.
All. And I'd like to thank Drs. London, Gallia, and Ramanathan for the opportunity to address this meeting. It's a great pleasure to be here again this year. I'm Haris Ludas, as you heard, and I'm a head and neck medical oncologist with the National Cancer Institute in Bethesda, Maryland, where I collaborate with head and neck cancer surgeon scientists of the National Institutes of Health. So following the really fantastic talks discussing the diagnosis and primary treatment of olfactory neuroblastoma, I'm going to be sharing some thoughts about the medical oncologist's perspective on olfactory neuroblastoma, but more with a focus to the recurrent metastatic disease, which is currently our main activity at the NCI, in contrast perhaps to other academic centers that work also in the primary treatment domain. Okay. So at the time of the initial diagnosis and primary treatment, the medical oncologist is less involved in decisions about treatment compared to the surgeons and the radiation oncologists. And if the disease is limited to the head, with or without involvement of the neck lymph nodes, as you heard, the oncologist's involvement may be in the form of giving chemotherapy, either before surgery, called induction chemotherapy, or after the surgery, called postoperative or adjuvant chemotherapy, usually as an addition to radiotherapy. The medical oncologist becomes more involved in the care of the patient following recurrence of the disease or when there is metastatic disease, beyond the neck, that is. If the recurrence is in the initial site of the tumor or in the neck lymph nodes, the treatment again may involve surgery or radiotherapy with or without chemotherapy. Or if these are not feasible, then therapy with anti-cancer medications will be needed. In the case of metastatic disease, therapy with anti-cancer medications is the main form of treatment. So what is the actual job of the medical oncologist? Our goal is to see the patient that has the cancer, not only the tumor, and we have a priority to maximize the benefit while minimizing the immediate and the long-term damage to the patient's quality of life, especially in recurrent cancer where cure may not be feasible. So one needs to understand that and plan ahead for perhaps repeated episodes of treatment in the future. So this involves decisions. One decision is about which treatment is the one appropriate for the particular patient, given the context with individual characteristics such as current physical condition, performance status, medical history, and comorbidities. What can the patient tolerate, that is? And another decision is when to treat, depending on the growth rate of the tumor that was discussed before in terms of grade by Dr. Hanna, or the amount of discomfort the tumor may be causing. So presence of the tumor may not be an indication for urgent, immediate treatment. One needs to discuss and understand the goals of treatment. And then when the treatment has started, the oncologist coordinates the management of problems and complications that are related to the treatment and the disease. Once the treatment has been completed, the oncologist follows up the patient over time to address survivorship issues and long-term toxicities, as well as to detect cancer progression or recurrence. So what are the broad categories of anti-cancer treatments that oncologists can use? In a broad overview, we could say that we have traditional cytotoxic medications, which you know as chemotherapy, and they are broadly active against cancer cells, but also against normal cells, so there is toxicity. Some examples are cisplatin, etoposide, cyclophosphamide, vincristine. There are many agents. There have been targeted medications, which in comparison to chemotherapy, which has been around since the 50s and 60s, have been a more recent development. Targeted treatments made inroads in the clinic around the 90s, and they are active against cells that have particular features, such as genetic mutations, markers on the cell surface, hormone receptors, high vascularity, and they can be less toxic than chemotherapy and actually quite efficacious sometimes. And later, more recently, immunotherapy was actually introduced to the clinic with a splash in the case of checkpoint blocking agents. And the goal there is to activate the body's own immune cells to fight the cancer. Again, immunotherapy may also attack normal parts, so there needs to be care from the oncologist to identify problems early on. And we have also the even more recent developments with cellular treatments like CAR T cells, TCR engineered T cells, NK cells, and macrophages, and the list goes on, where immune cells, either of one's own body or from another patient or another donor are engineered to attack markers that are existing on the cell surface or presented at the cell surface. These treatments may generate intense reactions. So how do we select among these treatments in general? We are guided by evidence. The highest quality of evidence comes from clinical research in the form of clinical trials, which test the treatment against another one, and ideally in a blinded and randomized manner so that we're not biased. And that way we try to establish the efficacy of each treatment and see which one is best. For this comparison to be truly useful, the testing needs to be conducted prospectively. This process of objective benchmarking leads to FDA-approved treatments and to what we call standard of care. In the absence of clinical research, we have to make assumptions based on retrospective data, which are usually heterogeneous and maybe of lower quality, or we extrapolate data from the treatment of tumors that look similar under the microscope, which is not, however, a guarantee that things will work the same way or that the needs of the particular tumor are the same. So this way, instead of a standard of care, we get clinical practice patterns, which may differ broadly among groups. So clinical research is necessary to produce robust evidence to guide treatment decisions. And how do we develop new treatments? So they start with extensive lab research, which we call basic research. And this involves detailed studies of the DNA, the RNA, the proteins of the tumors, and the way these interact with the cells and tissues around the tumor, such as immune cells and blood cells, etc. So basic research is absolutely dependent on biospecimens, which are samples of tumor and blood that we obtain properly when patients get involved in clinical research. So, in the particular case of olfactory neuroblastoma that is recurrent metastatic, what are the available treatments that we can choose from? Well, here's the point that the usual presentation of a medical oncologist includes a lot of medication names and regimens and plots, graphical plots of statistics for efficacy of the various treatment regimens. But in the case of olfactory neuroblastoma, there are no FDA-approved medications or standard of care. The available data are limited, and we don't know much about efficacy and toxicity in the way that we know for other types of cancers. We know stuff that comes from the respective descriptions of patient groups scattered over decades and with variations of the same treatment, so it's quite hard to tell. And when newer treatments get to be tried off-label, that means that we suspect that something might work and we want to try it. These results in individual patients may not get published, which is a missed opportunity because even small bits of information have some value for further guidance. And it has to be noted that this limited evidence base poses significant challenges for the development of clinical trials. So it's kind of a catch-22. So we know that we can use chemotherapy, mostly combination regimens based on platinum, cisplatin, carboplatin. There are case reports of targeted treatments, sunitinib or imatinib, some successes. It's the successes that get published, but cases that haven't been as successful are anecdotal. And we know that immunotherapy agents are being used, not really described in the literature. And recently, there have been publications describing the potential role of radionuclide therapy with somatostatin receptor 2 treatments. And these offer some potential for treatment in these cases. So, moving forward, we need thorough descriptions of the course of the disease over time and treatments, what we call natural history. And we have initiated such a research protocol at the NCI, which includes clinical, laboratory, and imaging assessments over time, along with collection of biospecimens. We also need high-volume data to determine optimal treatment strategies, and this can be a retrospective collection from several different institutions, such as one recent publication that was very informative based on international collaboration. And it can also be in the form of registries that accrue information and keep growing. We definitely need to increase basic research in the lab and get results translated to potential treatments that we then will test in the clinic. And in fact, Dr. London is leading a lab involved in such research in connection with the trials that we're working on. And obviously, since this is the focus of this slide, we need clinical trials. As mentioned, dedicated clinical trials for rare diseases such as olfactory neuroblastoma are very challenging. One way would be to encourage the inclusion of patients with olfactory neuroblastoma in larger trials, which can inform us with quality data, as has been the case with the radionuclide therapy. But we can also say that the NCI is a place that has the resources to conduct olfactory neuroblastoma dedicated trials. All our trials at the NCI in general regularly enroll patients from all over the United States. We cover traveling expenses and treatment costs. So we only need the participants. We do the design and provide the medications. And in fact, we are very soon launching our first clinical trial of immunotherapy for recurrent olfactory neuroblastoma. So we hope that we'll be adding something of progress to the field, and maybe we'll find ways to produce more collaborations and clinical trials that address this severely unmet need. Thank you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.